Hi all, welcome back. So our next topic is acute suppurative otitis media. It is commonly known as ASOM, acute suppurative otitis media. It is the infection of the middle ear. Acute suppurative otitis media. It is an acute inflammation of middle ear by pyogenic organism. So it is an acute inflammation of the middle ear cavity by pyogenic organisms. Here, middle ear implies middle ear cleft, that is eustachian tube, middle ear, attic, adytus, antrum and mastoid air cells. So these comprises of middle ear. So any infection in these structures can be called as acute suppurative otitis media. So acute inflammation of the middle ear, that means acute inflammation of eustachian tube, middle ear, attic, adytus, antrum and mastoid air cells can be mentioned as or can be called as acute suppurative otitis media. In this picture, you can see this is the external ear, right? External ear pinna and external auditory meatus, and here you can see the tympanic membrane, and between this tympanic membrane and this internal ear you can see the middle ear cavity, and this middle ear cavity is connected to oropharynx through the eustachian tube. So here this is the structure of middle ear. You can see malleus incus stapes, and this is the oval window, and this is the entrance to mastoid antrum in the epitympanic region. Above tympanic membrane it is known as epi, and so in this epitympanic region there is a opening towards the mastoid antrum, and this is the opening, and this is a bony canal. This mastoid antrum is a air-filled space in the bony cavity, right? So this opening will leads to this air-filled mastoid cavity, and this structure we can see in the temporal bone. So this is the tympanic cavity, and this is the adytus to mastoid antrum, and this is the mastoid air cells, and you can see this is the mastoid process. Mastoid process, you can feel it behind the ear canal. A bony projection is there behind the ear canal, that is known as mastoid process. So this is the normal structure of the ear, middle ear. So this you have to keep in mind for understanding this infection of the middle ear cavity. So now you understood, right, where all there is an infection, there is a chance of getting infection in this middle ear cavity, eustachian tube, or in the mastoid air cells region, adytus, antrum, anywhere. We will call that as, if it is an acute infection, then we will call it as acute suppurative otitis media, that is ASOM. Etiology. It is more common especially in infants and children of lower socio-economic group. So it is more common in infants and children of lower socio-economic group. Typically, this disease follows viral infection of upper respiratory tract, but soon the pyogenic organisms invade the middle ear. So typically the disease follows viral infection of the upper respiratory tract. It will follow after upper respiratory tract infection, but soon the pyogenic organisms invade the middle ear. So first it will start as an upper respiratory tract infection, and then it will invade to the middle ear, mostly via the eustachian tube. That is routes of infection. That first one is via eustachian tube. It is the most common route, and infection travels via the lumen of the tube on or along the subepithelial peritubal lymphatics, through lymphatic system or through the lumen of the tube. You saw in that picture, right? So the middle ear is directly connected to the oropharynx via this eustachian tube. So the infection can travel from behind the nase, upper respiratory tract infection, right? So from oropharynx and nasopharynx, the infection can very easily spread through the middle ear cavity through this eustachian tube. So infection can travel via the lumen of the tube or along the lymphatics. Eustachian tube in infants and young children is shorter and wider and more horizontal, and thus may account for higher incidence of infection in this age group. So, compared to adults, in a eustachian tube in infants are shorter, wider, and more horizontal. It's not like this, it's more horizontal, and there is a higher incidence of infection in this age group. You can see in this picture, this is a infants. Here you can see this is horizontal, this is little slanting. So here it is horizontal and it is narrow, it is not that long as an adult, and also it is wide open, so the infection can easily spread into the ear, middle ear. Breast or bottle feeding in a young infant in horizontal position may force fluids through the tube into the middle ear, and hence they need to keep the infant propped up with head a little higher. So while breastfeeding and bottle feeding, the child's head should be little up. Otherwise, if the baby is in horizontal position, then the chance of getting this through the eustachian tube to the ear, this milk getting into the middle ear is easy, and there is a chance of getting infection after that. So while feeding the baby, we have to propped up, the head should be a little up, higher place. Swimming and diving can also force water through the tube into the middle ear. So swimming and diving can also force water into the middle ear through eustachian tube. Next is via external ear. Traumatic perforation of tympanic membrane due to any cause open a route to middle ear infection. So any traumatic perforation of the middle ear or of the tympanic membrane, then the middle ear is open to external environment, then it is easy to get infected. Bloodborne, this is an uncommon route. Predisposing factors. So the factors which predisposes the middle ear infections are that which interferes with normal functioning of the eustachian tube. So anything that interferes with the normal functioning of the eustachian tube can cause middle ear infection. It could be a recurrent attacks of common cold, upper respiratory tract infection, and exanthematous fevers like measles, diphtheria, whooping cough. So recurrent attacks of common cold, upper respiratory tract infection, or fever like measles, diphtheria, whooping cough can cause a middle ear infection. Okay, as a secondary to these diseases. Infections of tonsils and adenoids, that it can easily spread to the ear if there is an infection in the tonsil and adenoid. Chronic rhinitis and sinusitis. So from there also it is easy to get infected to the ear. Nasal allergy, tumors of nasopharynx or packing of nose or nasopharynx for epistaxis. So tumors of nasopharynx or packing of nose or nasopharynx for epistaxis. Epistaxis is nothing but bleeding from the nose, right? So if we are packing with non-sterile cotton and all, there is a chance of getting infection to the ear. Also because of that, the pressure difference will come in the eustachian tube and the middle ear. So there also there is a chance of getting middle ear infection. Cleft palate. In the cleft palate, kids having cleft palates are also, it's open, so it is easily, there is a chance of getting infection in the ear. So these are the predisposing factors for middle ear infection. Acute suppurative otitis media. Bacteriology, which all bacteria can cause acute suppurative otitis media. Most common organisms in infants and young children are Streptococcus pneumoniae, Haemophilus influenzae, and Morosella cataralis. So these are the bacteria which cause in infants and young children. Other organisms include Streptococcus pyogenes, Staphylococcus aureus, and sometimes Pseudomonas aeruginosa. So these can also cause ASOM, but mostly the most common bacteria are Streptococcus pneumoniae, Haemophilus influenza, and Morosella cataralis. Next comes the pathology and clinical features. So I hope the etiology and root of infection and the bacteria organisms which cause this disease are clear for you. So next comes the pathology and the clinical features. The disease runs through the following stages. There are 5 stages in this disease. In that, first one is stage of tubal occlusion. Edema and hyperemia of nasopharyngeal end of eustachian tube blocks the tube, leading to absorption of air and negative intratympanic pressure. So, edema and hyperemia of nasopharyngeal end of eustachian tube blocks the tube, leading to absorption of air and negative intratympanic pressure. So, there is an edema in the lower end of eustachian tube. So, eustachian tube lower end, that is near the nasopharynx, there is an edema and that is blocking that eustachian tube. It will leads to absorption of air and negative intratympanic pressure. In the tympanic cavity or in the middle ear cavity, there is a negative pressure, and that will cause the retraction of tympanic membrane. There is retraction of tympanic membrane with some degree of effusion. Effusion means fluid collection in the middle ear, but fluid may not be clinically appreciable. So, because of this edema in the end, nasopharyngeal end of eustachian tube, the eustachian tube will get blocked, and because of that, there is a negative pressure inside the middle ear cavity, which will cause the retraction of tympanic membrane, that is pulling inside of the tympanic membrane, and there will be little effusion in the middle ear, that is little fluid collection in the middle ear cavity that may not be clinically appreciable. It cannot be seen at the otoscope. So this is a normal tympanic membrane. You can see this is the normal tympanic membrane. This is the handle of Malleus. This is the cone of light, and this part is known as pars flaccida, and this is pars tensa. So if it is there is in the stage of tubal occlusion, there is an occlusion in the eustachian tube, then there will be retraction of tympanic membrane. The retraction of tympanic membrane looks like this. Okay, if we see with otoscope, we can find out this one. So otoscope is the instrument we use to examine the ear. Okay, so we will use this one to examine the ear, and you can see this there is a retraction of tympanic membrane inside. There is a negative pressure inside the middle ear cavity, and this tympanic membrane got retracted, that is pulled back behind, pulled inside the middle ear. So this is how the retraction of the tympanic membrane looks like. Next comes the symptoms. In the initial stage, what all symptoms can be seen? So deafness will be there, and earache are the two symptoms. You saw that retraction is there. So the tympanic membrane is like a drum, right? If that sound hit the drum, it will vibrate, and the vibration is passed through the ossicles, that is ear bones, and it will be transmitted to the internal ear. But if it is retracted, it is because of the negative pressure, it is pulled backward, then that drum like that vibration cannot be formed, right? So there will be deafness, and because of this retraction, there will be earache also. There is generally in the initial stage, there is no fever. Signs: tympanic membrane is retracted with handle of Malleus, assuming a more horizontal position, prominence of lateral process of Malleus, and loss of light reflex. So, in the previous slide, I showed a picture of retracted tympanic membrane, right? There it is, the handle of Malleus is more prominent, and you can see a process of Malleus, and the loss of light reflex. Right reflex cannot be seen there. Tuning fork test shows conductive deafness. We will test hearing using a tuning fork, right? So if we do tuning fork test, we can understand it is a mixed or conductive or sensory neural deafness. So if we do tuning fork test, we'll get to know that it is a conductive deafness, because there is a problem in the conduction, right? So it is retracted, so there is a problem in the conduction of sound. So there will be conductive deafness. So this is This is what we'll see in tubal occlusion. So stage of tubal occlusion, nothing is there. Eustachian 2 is getting occluded or it got blocked. So negative pressure is formed and there is a retraction of tympanic membrane. Because of that there is deafness and pain. Next stage is stage of pre-separation. Pre-separation, before separation. If tubal occlusion is prolonged, pyogenic organisms invade tympanic cavity causing hyperemia of its lining. So, this occlusion is prolonging, then these pyogenic organisms will invade the tympanic cavity, the middle ear cavity, and cause the hyperemia of the lining of the middle ear. Inflammatory exudate appears in the middle ear. If inflammation is there, the exudates will come and it will get collected in the middle ear. Tympanic membrane becomes congested. Not only the middle ear lining will get hyperemia, the tympanic membrane will also get congested. Symptoms: there is marked earache which may disturb sleep and is of throbbing nature. So there is a slight pain, marked earache will be there which is throbbing type. Deafness and tinnitus are also present but complained only by adults. Deafness and tinnitus will also be there but childs and infants won't notice that, they won't complain. If it is seen in an adult, they will come and complain. Usually child runs high degree of fever and is restless. Kids will show high fever and they will be restless. Signs: to begin with, there is congestion of pars tensa, leash of blood vessels appear along the handle of malleus and at the periphery of tympanic membrane, imparting it a cartwheel appearance. So, leash of blood vessels appears along the handle of malleus. You saw a handle of malleus, right? So, there the leash of the lines of blood vessels will appear and at the periphery of the tympanic membrane also, imparting a cartwheel. Cartwheel, you know, right? Bullock cart wheel like appearance. So bullock cart is a round and with a rails, right? So a cartwheel appearance can be seen. Later, whole of tympanic membrane including pars flaccida become uniformly red. So pars flaccida is the upper portion, so that whole tympanic membrane will become red. Tuning fork test will again show conductive type of hearing loss. This is the cartwheel appearance. This is the handle of malleus and from there you can see the release of blood vessels. Around also it is fully red. So this is the cartwheel appearance of the tympanic membrane. So these are the in the stage of pre-separation this will happen. So it is the tubal occlusion is prolonging, means pyogenic organisms will invade and the inflammation of the middle ear cavity will happen, and because of that exudates of the inflammation will come and collect in the middle ear. Not only in the middle ear lining, there will be an inflammation or redness or hyperemia in the tympanic membrane also. So if we examine using otoscope, we can see this cartwheel appearance in the tympanic membrane. And also the kids will have a high degree of fever and adults will complain of deafness and tinnitus. Stage of separation, that is the third stage. This is marked by formation of pus in the middle ear and to some extent in mastoid air cells also. So, stage of pre-separation. Now it came to the stage of separation. In stage of separation, pus is already formed not only in the middle ear cavity, sometimes in the mastoid air cells also. We saw that in the previous slides, right? Mastoid air spaces. So remember, there also the pus got filled. Tympanic membrane starts bulging to the point of rupture. So, tympanic membrane is bulged and it is about to rupture. If there is a pus collection, it has to come out, right? So, in abscess and all, if there is a pus collection, there comes a pus point and the pus will drain out by itself. That is the body's mechanism. So, in stage of separation, the symptoms are earache becomes excruciating, that is, it becomes very severe, deafness increases, child may run fever of 102 to 103 degree Fahrenheit, his child will have high fever, this may be accompanied by vomiting and even convulsions. And a signs, tympanic membrane appears red and bulging with loss of landmarks. It's fully bulged. Handle of malleus may be engulfed by the swollen and protruding tympanic membrane and may not be discernible. So we can't see the handle of malleus because it is swollen. That much it is swollen. A yellow spot may be seen on the tympanic membrane where the rupture is imminent. So you can see in this stage of separation there is an pus point or a yellowish spot where in the tympanic membrane where it will rupture and the pus will come out. So it's full bulged. We can't see the handle of malleus and all. Here it can be make out little bit, but normally it will be like fully bulged, and you can't make out anything, and there will be a pus point, especially in the antero-inferior part of the tympanic membrane because of gravity. In pre-antibiotic era, it means not in the antibiotic era, one could see a nipple-like protrusion of tympanic membrane with yellow spot on its summit. So you can see a protrusion of tympanic membrane like a nipple-like protrusion in the tympanic membrane. That is a pus point. Tenderness may be elicited over the mastoid antrum. So in the mastoid antrum, tenderness will be there. X-rays of mastoid will show clouding of air cells because of exudate. So because of this exudate, if you take an X-ray of this mastoid part, this clouding of that area, air cells can be seen. So tenderness will be there in the mastoid region. So this is the stage of separation. So in stage of separation, it is already separated, and the middle ear cavity and even the mastoid air cells can be filled with the pus, and if we see the patient will come with the symptoms like a high fever, and sometimes kids will have vomiting and convulsions also, and also signs, that is if we do examination we can see this tympanic membrane is fully bulged with the pus point, and where it will rupture in the next stage. Okay, so that is about stage of separation. So first stage is stage of tubal occlusion, where the eustachian tube will get blocked. Second stage is pre-separation. Before separation there will be because of this tubal occlusion, there will be a negative pressure, and the pyogenic organisms invade into the into our middle ear, and there will be exudates, and that will collected in the eustachian tube, and there will be cartwheel appearance in the pre-separative stage, and in the separative stage it will be completely bulged and pus point is seen. And next is stage of resolution. Here what happens is the tympanic membrane ruptures with release of pus and subsidence of symptoms. Here the tympanic membrane is ruptured and the pus is released, and the symptoms are subsided. Inflammatory process begins to resolve. So the inflammatory process resolves. If proper treatment is started early, or if the infection was mild, resolution may start even without a rupture of tympanic membrane. So if the proper treatment is started, antibiotics is given early stage, or the infection was mild, then resolution may start even without rupture of the tympanic membrane. There won't be any rupture of the tympanic membrane. Symptoms: with evacuation of pus, earache is relieved, fever comes down, and child feels better. Because it is ruptured and the pus came out, earache will reduce and also fever will come down. And signs: external auditory canal may contain blood-tinged discharge which later becomes mucopurulent. So we can see a blood-tinged discharge or a mucopurulent discharge in the external auditory meatus. Usually a small perforation is seen in the antero-inferior quadrant of pars tensa. So in the pars tensa, in the antero-inferior part, we can see a small perforation through which this pus came out. Hyperemia of tympanic membrane begins to subside with return to normal color and landmark. So it is a stage of resolution. So there it is going back to normal. So tympanic membrane hyperemia reduces and the normal color will come back. Next stage is stage of complication. So first stage is stage of tubal occlusion, stage of pre-separation, stage of separation, stage of resolution, and the final stage is stage of complication. If virulence of organism is high or resistance of the patient is poor, resolution may not take place and disease spread beyond the confines of the middle ear. So, if the resistance of the patient is low and also the virulence of the organism is high, then it will not go to resolution, but it will go beyond the beyond structures of a middle ear. It will spread to other parts. It may lead to acute mastoiditis. Mastoiditis is a infection in the mastoid region. Subperiosteal abscess, that is subperiosteal abscess, that is subperiosteal region is the region which supports the globe, the bony structures. Facial paralysis. Labyrinthitis. Labyrinthitis is internal ear. Petrositis is nothing but the infection in the temporal bone where the ear is situated. Extradural abscess. Extradural abscess is the abscess or pus collected between this in the epidural space. Pus collected in the epidural space is known as extradural abscess. Meningitis, brain abscess, or lateral sinus thrombophlebitis. So all these things can happen if it is not resolved and the virulence of the organism is high. It will go to next stage, that is next structures the infection will pass. So this is stage of complication. So these are the pathology and clinical features of ASOM, acute suppurative otitis media. Hope you understood these 5 stages. Next comes the treatment of ASOM, antibacterial therapy. So antibiotics can be given. Decongestant nasal drops, and oral nasal decongestants can be given in the initial stages because tubal occlusion is there, right? So that is a main reason for this infection. So in the initial stage there will be tubal occlusion. For that we have to give decongestant nasal drops. So that will go and act in the lower end of the eustachian tube and helps to reduce that edema, and the pressure will get maintained and it won't go to the next stages. So they used to give decongestant nasal drops or oral nasal decongestants. Analgesic and antibiotics, that is if there is earache and fever, then they will go for analgesic and antibiotics. Ear toilet, that is after rupture, if there is a discharge in the ear, it is dry mopped with the sterile cotton buds and a wig moistened with antibiotic may be inserted. So if the discharge is there, it should be dry mopped. It should be mopped with the sterile cotton, and after that they will dip the antibiotic drops and the wig in the antibiotics and put it inside the ear, like how we will use Karnapichu. Next comes dry local heat. If we give dry, it helps in, if there is severe pain, then we can give this dry local heat that will relieve the pain. Meningotomy, it is the incision. It is incising the drum to evacuate the pus, and is indicated when the drum is bulging and there is acute pain. There is an incomplete resolution despite antibiotics when drums remain full with persistent conductive deafness, and there is persistent effusion beyond 12 weeks. So these antibiotics are not acting, then we can go for meningotomy. It is after there is acute pain, then we can just put an incision and remove the pus. Or incomplete resolution after giving antibiotics also it is not resolving, then this effusion is there after 12 weeks also, then we have to go for meningotomy. So these are the treatments. So this is a chart showing the treatment. Acute otitis media, antibacterial therapy can be given. If a good response is there, then we will ask them to continue for 10 more days and complete resolution. If it is not there, then earache and fever persists, means then we have to give another antibiotic, or we have to do culture of this this pus. Then apt antibiotic should be given. Periodic checks for 12 weeks. So this is the treatment for acute suppurative otitis media. So that's about acute suppurative otitis media. Hope you all understood ASOM or acute suppurative otitis media. Thank you.